I'm particularly pleased to present our next presenter. What if you, yes you, could learn pain relief in just a single session? Our next speaker made that happen. Dr. Beth Darnall is a Stanford professor, psychologist, scientist, and global force in pain innovation. Her Empowered Relief program is now taught in 30 countries and 8 languages, and I give it to all my patients. She's briefed the US Congress 3 times, spoken at Davos, and has more acronyms in her bio than most people have contacts in their phone. It's true. If you want to know how your brain can unlearn pain, she's your person. Please welcome Dr. Beth Darnall. Thank you. Okay.
Perfect. Thank you. It's such an honor to be here and share some of my work. I am a pain psychologist scientist, and I both develop and investigate interventions that provide pain relief, analgesia, and also for opioid reduction where that's relevant and desired. So I want to start off with a question to all of you and just think about what's the biggest problem in pain care. I submit that the biggest problem in pain care is access to care. People can wait a month, a year, multiple years trying to get the care that they need, and sometimes they never receive it. Even when pain care is provided, people don't know if they're walking through the right door. Are they being provided the right treatments? The ones with the lowest risks first. Let's take surgery as an example. How do we help people have less pain after surgery? This is Judy. She's just had breast cancer surgery, and she's following her doctor's orders, and she's taking her medications as prescribed. But there's something important missing from those orders. People can work directly with their central nervous system to provide themselves with relief. And this approach is important, but it needs to be taught to our patients, provided to them as part of their medical and surgical care plan. After all, surgery is just a controlled injury, and the brain registers and interprets injury and pain as a threat, a problem to be escaped. Now, healing from surgery requires that we quell pain, that we calm the central nervous system to stage it for an optimal state of recovery. And we want to apply this as early on after surgery as possible. Now, a biopsychosocial approach is low risk, low cost, and there's no side effects typically. I developed a single session, 90-minute intervention called Empowered Relief that teaches people how to calm their central nervous system, to dampen pain processing before and after surgery, and also for chronic pain, which I'll talk about next. It includes simple skills and about 20 minutes a day to teach people how to train their nervous system towards relief. So their heart rate stays lower, their breathing rates stay lower, and it stages mind and body for an optimal state of recovery after surgery. In our first published randomized controlled trial, we showed that people like Judy, who received Empowered Relief after breast cancer surgery, required less opioid medication as they were recovering compared to people who received a health education intervention. And we next studied it in people undergoing orthopedic trauma surgery. And in this study, people received an iPad in the hospital after surgery on postoperative days 1, 2, or 3. And they received the Empowered Relief intervention that way. And we found that people who received Empowered Relief had less pain after their surgery and all the way to 3 months later, relative to people who received a general health education intervention. And in a scoping review of the medical literature that we just conducted, we found that empowered relief for surgery is the only behavioral perioperative intervention that is being applied widely for post-surgical recovery. And it's most often being delivered via Zoom classes by live instructors, so it's very low cost. In 2019, the US Department of Health and Human Services cited empowered relief for surgery as a promising way to address post-surgical pain at scale. So I want to put forward this idea that a brief pain relief skills intervention can help people recover from surgery more quickly, low cost, and it can be integrated directly into the medical setting. This is speed, scope, and scale. Now let's talk about chronic pain, which you know impacts 20% of the world population. Now, medical approaches are important, but alone are insufficient. We really need a whole person approach, and people need to fundamentally understand how they can modulate their own central nervous system to gain relief. These approaches typically involve people learning various skills, gaining resources, taking those skills and applying them into action plans. Then they use those skills on a daily basis. Fundamentally, they understand which daily choices provide them with relief. And this approach is often delivered by a psychologist. And while effective, this treatment is often inaccessible due to the fact that we have too few psychologists and due to the fact that the treatments often involve up to 16 hours of face-to-face time with a therapist. So the treatment formats themselves are creating a barrier. We studied this about a decade ago, and unsurprisingly, patients told us that attending 16 hours of treatment is often infeasible for them, but the vast majority of people aren't even offered this option at all. So one key solution is to look beyond the traditional formats themselves to new innovations. And while I touched on empowered relief in the surgical context, I want to provide some more detail on it here. Empowered relief is a one-session intervention that rapidly equips individuals with effective pain relief skills. It's didactic. This is not therapy. In a 2-hour session, people gain 3 core pain management skills. They complete a personalized plan for empowered relief. They download a binaural audio file app that they can put on their phone or on a personal computer device, and they can use that daily and ongoingly for continued relief. Because of its format, large class sizes are possible. So at Stanford, we register 150 individuals in a single empowered relief class. Now, we've conducted 11 clinical trials on empowered relief, and I just want to touch on the results for a few of them now. In this first study, we enrolled 263 individuals with chronic low back pain, and we randomized them into one of 3 groups. Either they received a single session of health education with no skills, or they received 1 session skills-based empowered relief, or they were randomized to receive 8 sessions of what is considered the gold standard behavioral therapy for chronic pain, cognitive behavioral therapy. And we hypothesized that this 1 session of empowered relief would confer about equal benefits for symptom reduction at 3 months as the gold standard 8-session CBT. So it was a really high bar for us to hypothesize that 1 session would be about as effective as 8, 3 months post-treatment. And in fact, that was what we found, and our primary outcomes were pain catastrophizing, pain interference, pain intensity, And we also found similar patterns of clinically meaningful benefits across a range of secondary outcomes, which you see listed on this slide: sleep disturbance, depression, anxiety. So we were learning that this intervention was multidimensional and somewhat all-purpose, while reducing treatment burden by 80%. We next looked to see if these benefits would be sustained at 6 months, and we found that they were largely. And we next studied online delivered empowered relief. That expands access if people can get the treatment online. And in this study, we enrolled people with chronic pain of any type, and they were randomized either to online empowered relief or to usual care in the clinic. And we found a similar pattern of multidimensional benefits that were clinically significant 3 months post-treatment with moderate effect sizes. Now, these last two studies that I just described to you, empowered relief was delivered by a psychologist, by a pain psychologist. In the United States, we have 150,000 psychologists. We have 5.7 million nurses. So if we're going to scale pain treatment, we need to look beyond psychologists only and increase the scope and include other disciplines, other professional disciplines to deliver the intervention. So I was really excited when Holly Watson wanted to conduct this randomized controlled trial of nurse-delivered empowered relief. We partnered with the American Society of Pain Management Nurses, trained nurses in empowered relief, and then conducted this national online trial. 150 people with chronic pain were enrolled and randomized, and the primary study endpoint was 2 months post-treatment. And what we found was that empowered relief was effective and imparted clinically meaningful reductions for pain intensity, pain catastrophizing, depression, anxiety, improving self-efficacy. This similar pattern of multi-dimensional benefits. Now, the highly structured format of empowered relief allows for interprofessional delivery with high fidelity to the treatment. How many of you have heard about Marfan syndrome or are familiar with it? Okay, I see a lot of hands. So you know that Marfan syndrome is a rare connective tissue disorder or disease, impacts multiple body systems and organs, and it's associated with a high degree of pain comorbidities. Marfan is both a rare disease and it is rarely studied. We looked to see how many pain treatment studies have been conducted in people with Marfan. Do you know how many? 0. Not a single one. So we conducted the first. And we partnered with the Marfan Foundation. We enrolled 108 individuals with Marfan syndrome. And we wanted to see, could we treat everyone at the same time? And in so doing, would people gain benefit? 92 people showed up for a single empowered relief class en masse. The treatment was delivered online. We had high satisfaction ratings, and at 3 months post-treatment, we found clinically meaningful, significant benefits across a range of outcomes. And you can see here, these were just our primary outcomes: reduced pain intensity, pain interference, and pain-related distress or pain catastrophizing. And a whole host of secondary outcomes improved. Today, empowered relief is being delivered in 30 countries, in 8 languages, by 1,600 certified instructors. And we receive about 15,000 visitors to our Empowered Relief app page every month. These are just some of the healthcare organizations that have adopted empowered relief and have embedded it throughout the healthcare systems and networks. And in Canada, Dr. Junie Carrière, who is at Sherbrooke University, she has funding from CIHR and has been investigating empowered relief in primary care delivered by physical therapists. And she's studying this in people with acute low back pain episodes. And Regina Visca, she has been a real pioneer for empowered relief in the Quebec province. She has empowered relief integrated into new interdisciplinary primary care programs for chronic pain. It's being applied in team-based family medicine clinics, as well as in primary care access points. So this is for patients who don't have family medicine physicians, and they're often cases that are referred from the ED. And she's also applying it in local community service centers. And this is especially serving most vulnerable populations. You can also find it in some Canadian VAs, as well as in Pain BC. We have tailored versions of empowered relief. I described the one that we have for injury or surgery. We also have a version for people in the military and veterans. And we partnered with the California Department of Corrections and Rehabilitation to tailor empowered relief to the corrections setting so that incarcerated individuals can receive it in primary care throughout the California prison system. So we've really scaled throughout the California prison system. Researchers and clinicians at the Stanford University Pediatric Pain Clinic have tailored empowered relief to youth. And Dr. Alexandra Neville received funding to develop a complementary version for parents and caregivers, and so that is in development now. We have digital versions of Empower Relief that enable on-demand access. They're interactive, they tie into the EMR, they're secure, and we're applying this in different patient populations: chronic pain, surgery, workers' compensation. These automated on-demand options facilitate access, but they'll never really obviate the need for live instructor-delivered classes. They simply offer patients a choice. And with patient choices come better patient engagement. And with better patient engagement, they get better treatment and better outcomes. Our vision is empowered relief for every patient, everywhere. Thank you.
Well, thank you very much, Beth. A couple questions online for you. You got about 8,000 fans right now. So the first one was, I think I know the answer, but do you have to be a psychologist to facilitate empowered relief?
You do not. We conduct certifications through Stanford CME, and virtually any licensed clinician can become a certified empowered relief instructor. So nurses, physicians, physician assistants, occupational therapists, physical therapists, you name it.
And I'll give you the last one. So how short can you get this down to? Can you do 30 minutes? Can you do 10 minutes?
You know, it is a great question. We have a version for surgery that's 80 minutes, and we have one that's even a little bit briefer than that. It needs to be comprehensive enough that people understand the rationale, the importance for the skills, and to learn those skills and be motivated to use them. But I think, you know, we're playing around with, can we get that? Can we make it even briefer than it is now?
Thank you so much.